Hello, my name is Gwen Spurl, and I'm chairman of the Users Steering Committee programs here at the Cummings Center. Bonjour, mon nom est Gwendolyn Spurl et je suis président du comité des usagers des programmes adaptés ici au Centre Cummings. The Cummings Center is a nonprofit community center of excellence. It connects people 50 years and older to the arts, education, health, and wellness. It offers a wide variety of programs adapted to the special needs of individuals with neurologic and other disorders. Programs go all the way from meditation to boxing. The agency is dedicated to enhancing the quality of life of seniors and promotes positive attitudes about aging. It emphasizes volunteer involvement in all aspects of community life. The Cummings Center is thrilled to embark on this partnership with Parkinsons Canada and is looking forward to a long working relationship. We're joined today by Danielle Blain, Regional Director of Parkinson Canada, and Marina Joseph and Jackie McAuliffe, who have joined us from Parkinsons Canada in Toronto. Maintenant, je voudrais vous introduire Danielle Blain, qui va introduire notre invité, le Dr. Ron Postuma. Thank you.
Thank you very much, Dr. Spurl. Bonjour à tous. Merci d'être ici aujourd'hui. Hello, my name is Danielle Blain. I am Managing Director for Parkinson Canada and Quebec. First, I would like to welcome you all and thank you for joining us today during Parkinson Awareness Month. I would also like to thank the Cummings Center and Mrs. Stephanie Novick for your friendly partnership in making this event possible. Parkinson Canada is the national voice for Canadians living with Parkinson's disease. It has been established since 1965 and has offices coast to coast, including a bilingual office in Montreal, where you are more than welcome to contact us for anything you need. We provide education and support services to people living with Parkinson's, caregivers, and healthcare professionals. For more than 3 decades now, Parkinson Canada operates a national research program which funds innovative research for better treatments and a cure for this disease that changes all aspects of daily living. Research gives us hope. If you have not done so on your way in, I invite you to stop by Parkinson's Canada and Quebec's booth in the lobby where you can speak with one of my colleagues, or you may pick up a number of publications, including the guide, I see many of you already did, including the guide of the Nonmotor symptoms of Parkinson's disease, which is co-authored by Dr. Ron Postuma, who is here with us today. Dr. Postuma is Associate Professor of Neurology at McGill University at the Montreal General Hospital. He obtained his medical degree from the University of Manitoba and trained in neurology at McGill University. He has subspecialty training in movement disorders obtained from the Toronto Western Hospital and a master's degree in epidemiology and biostatistics from McGill. Dr. Postuma's primary research focus is on the interaction between sleep and movement disorders, with ongoing research projects that include clinical trials for insomnia and somnolence in Parkinson's disease, studies of restless leg syndrome prevalence, and work on rapid eye movement sleep behavior disorder. Dr. Postuma is also the current chair of Parkinson Canada's Scientific Advisory Board. Please join me now in welcoming Dr. Ron Postuma.
Hello, everyone, and welcome on this miserable day outside. I'm glad you managed to make it here. It always seems harder than it actually is, but all that slush is not fun, I know. And we're going to talk about light therapy a little bit. Well, briefly, I'm going to mention it, but I don't think we're going to get much today, so we'll have to see. So I'm going to talk to you about sleep and Parkinson's disease in general. Juste à dire, je peux répondre aux questions au fin en français aussi. Either language is fine with me. Okay? So I'm just going to first by outlining the idea of non-motor Parkinson's disease by contrasting it with motor Parkinson's disease. And we'll just sort of go with a little bit of biology about why Parkinson's disease should involve the non-motor systems, and then in particularly sleep. And then we'll do a sort of practical guide to dealing with sleep issues in Parkinson's disease. And we'll focus on the three that are really the big problems for most people, which is insomnia, sleepiness, and REM sleep behavior disorder. So if I was going to give a talk in 1990 or 1995, this would be the talk about Parkinson's disease. And so Parkinson's disease is a motor disease as of 1990. And so the main features of this are the tremor, and that's a tremor that you have at rest. So it's not a tremor when you're doing something, it's a tremor that you have when the hand is sitting there or when it's holding a posture for a long time. And that's what everyone thinks about when they think about Parkinson's disease. The other major motor symptoms of Parkinson's disease we call bradykinesia, or slowing movement or less movement. Okay? Early on, this is clearly the most important motor symptom for people's quality of life. And this really has manifestations everywhere. So the hands are slow, they can feel clumsy. A lot of people feel that their hands are weak. In fact, their hands are not weak at all. The strength is perfectly normal, just the ability to move them, to control them, to move quickly is impaired. And all the movements are less. So that means things like the handwriting gets very small. The voice becomes quiet and monotone, and it tends to fatigue and drift off at the end of a sentence. That sort of thing is what we often notice. And in fact, the handwriting does the same thing. The first three letters are pretty good, and then it sort of drifts into nothing. And then the walking is slowed down as a result of that, and the steps become small. So basically every movement that you do is just less. And in fact, often people themselves are not as aware of the movements as those around them. And so it's usually spouses who notice, whoa, he's really, really slow, or she's really, really slow. And the patient doesn't always feel it that much, early on at least. It's an interesting experience to watch yourself on video sometime. The other thing is rigidity. Now, rigidity means stiffness of the muscle. That you don't really feel that. It can cause a little bit of ache in the muscle sometimes. Okay, and then there's the postural changes, which is the stooped posture, and excuse me, and the difficulty with balance that goes with that. And so that's motor Parkinson's disease. And so when those of you who are patients here showed up at your doctor's office, the doctor first defined Parkinsonism. And what that meant was the key is a bradykinesia, which is, you see, I see many of my patients here, you do this and then you see it sort of drop off a little bit and get a little bit slower. That's the key feature of Parkinson's disease. And then you have to have at least one of rest tremor, rigidity, and poor balance. And in fact, we've just recently wrote the new criteria for Parkinson's. Poor balance is no longer part of the criteria. Of course, it's a feature, but it's not a defining feature. And so the point being, you can have Parkinson's disease without having any tremor at all. And in fact, almost half of people don't have any tremor at all. We're still in 1990, okay? And I'm showing you what Parkinson's disease looks like, okay? So if you had to look at this brain, let's see if the pointer will work. Yes, it does. So this is the area that we're really interested in. I don't know if you guys would think about what would be the area that's abnormal, okay? And I think you'd think naturally that this black stuff, well, that must be no good. But in fact, that's what's normal, okay? And this is a patient who's died, obviously, and has had Parkinson's disease. And this is an area of the brain that we call the substantia nigra. And that area is responsible for secreting dopamine, and that's what keeps you moving and keeps you, functioning relatively well. And essentially what's happening in Parkinson's disease is that area is aging, okay? Aging means cells are working less, the cells start to die, and so there's not enough dopamine, and that's why we give you dopamine back and you get so much better. Okay? So we're still in 1990 for the last half of this slide, okay? And so what you see on a person who's died, if you would look at their brain under a microscope, you see something called a Lewy body. And it's this thing where their arrow is right there, this sort of pink rim, and surrounding it actually is a sort of what we call a cytoplasmic ring, which is called a Lewy body. And these were always very, very difficult to find. You really have to search all over the brain to find these things in a patient, even a patient with fairly advanced or bad Parkinson's disease. And then, in 1997, there was a description of a family. There's only been a couple of families in the world, but this was a massive family. They were Italian. And it was discovered that they had a mutation in a protein that was called alpha-synuclein. Okay, and everyone with that mutation got Parkinson's disease. Okay, now that's a rare form of Parkinson's disease, but when people realized that was important, protein was very important, they started to look for it. You can do this with pathology stains, and when you do that, these Lewy bodies that used to be really, really tough to find are now easy to find everywhere. Okay, and it turns out that these Lewy bodies are all over the place, but we just weren't good at finding them because we didn't have the right protein. Okay. And this changed everything, because now that the Lewy bodies are easy to find, you can start to look for disease in areas outside of where there's tons of them. Okay? And this is probably, in the 2000s anyway, probably one of the most important advances in Parkinson's disease. And there's many variations of this, but this is called the BRAC staging system of Parkinson's disease. And what BRAC proposed was that, in fact, Parkinson's disease isn't even a motor disorder when it starts. That Parkinson's disease starts, my pointer comes back, here, okay, and here, which are two areas of the brain that are connected to the olfactory area and connected to what we call the autonomic areas, the dorsal motor nucleus of the vagus. Long and complicated, and then what Parkinson's may do is walk, march, up the brainstem, next getting areas involved in sleep and mood, and that's why we're talking about sleep, okay? And only at stage 3 does it hit that motor area that I showed you earlier, okay? And in fact, because we have lots of built-in redundancy in our system, we don't always feel subtle changes. It's not until the Parkinson's is at 4, 5, and 6 that you're even showing up with the doctor with your Parkinson's symptoms. Now, this is not true for everyone. Some people come in with a very pure motor Parkinson's disease, but this is what happens about 80% of the time on average. And so the real implications of this is that we should not be thinking of Parkinson's disease as a disease of the motor system, but as a disease of many areas of the brain, and most importantly, the non-motor areas. So, why didn't we know about all this non-motor stuff in 1970, for example? We're going back a little bit. It was because if you would have gotten Parkinson's disease in 1970, you would have actually been very, very disabled very quickly. Okay, you would have been in a nursing home probably within 3 or 4 years. You would have died 5 or 6 years later from the severe motor disability of Parkinson's disease. But levodopa was invented in the 1970s, and this was a miracle. And there's a movie, you can watch it if you want. It's not about Parkinson's, it's about a related condition called Awakenings, with where people got levodopa for the first time, and they woke up, they became normal, and they acted, they went back to their jobs, they did normal lives. This is how effective levodopa is. 80s and 90s, we were dealing a lot with the difficulty that it's tough to keep the levodopa dose stable. And so we're trying all the time to keep it stable. It works, it doesn't work, works, doesn't work, especially for young people, not so much for older people. And so we developed all these things to try and work on the dopamine system a little bit better. And in fact, now the dopamine system essentially can be taken care of. There's the duodopa system, for example, there's the brain surgery system, but for most people it's just a combination of medications that takes perfectly good care of your dopamine system. But now people are now functioning well, they're living much, much longer, and so now we can see the stuff that was always there, and we didn't notice. And this is what I call the everything else about Parkinson's disease, and there's no question that this is the most important frontier of Parkinson's disease. And so this is a list of some of the non-motor symptoms of Parkinson's disease. Now, not everyone gets them, okay, but everything on this list is experienced by at least a third of patients with Parkinson's. So there's the motor symptoms that don't respond to the dopamine because they're related to other areas of the brainstem. So things like drooling, trouble swallowing, difficulty with the balance. The freezing isn't always levodopa responsive. So those are non-dopaminergic motor symptoms. We can have mood changes, depression, actually anxiety more commonly than depression. We can get visual changes. These are relatively subtle, not a big deal, but one of the reasons you might have difficulty driving at night is because you have a bit of difficulty telling the difference between various shades of gray, and that's all you have at night, of course. There's autonomic dysfunction. Almost everyone gets constipation at some point. Urinary dysfunction. A lot of people have to go to the bathroom more often. Men can have trouble getting erections. Blood pressure can drop when you stand up. Okay, there's sleep disorders, which I'm going to go through in detail. Okay, some people can get hallucinations. That's later on in the disease, and cognitive impairment definitely can happen again later on in the disease, and for people who are older. And again, these we didn't we didn't know about them in 1970, 1980, 1990, because they were hidden under this flood of motor symptoms. And now that we know that this is the bit of Parkinson's disease that is the most difficult to treat, because we don't have magic pills for these conditions like we do for others. That being said, we have lots of pills to help all of these. So if these are issues with you, I notice many of you have a book in front of you which outlines some of that, which we wrote because they're under-recognized. And there are many, many things that can be done for all of these. Not everything can be fixed, but a lot of things can be helped. And so with that, okay, that was a lengthy introduction, but I did it on purpose because I wanted to make you aware of all these non-motor symptoms, and I encourage you to sort of read up on them, maybe the book that you have in front of you, something like this, and go looking for these things that may be bothering you and could be fixed, particularly with the help of your neurologist. So let's now concentrate on why I was asked to come here, and let's talk about sleep specifically. So that's my daughter when she was born. That's 11 years ago now, but yeah, anyway. Okay, we got 3 main sleep problems in Parkinson's disease that are probably affecting your daily life. So let's just focus on the ones that are an issue. And that's insomnia, sleepiness, and REM sleep behavior disorder. And we're going to go through these 3 things in order. So insomnia in Parkinson's disease. Now, when people think about insomnia, they usually think about a person who goes to bed and can't get back to, and can't fall asleep. Okay, and maybe when you were younger, that was what you usually would deal with, tossing and turning in bed, can't fall asleep at night. In fact, that's an uncommon problem in Parkinson's disease. It's in fact less common to have that kind of insomnia than a person without Parkinson's disease. The trouble with most people with insomnia and Parkinson's disease is difficulty staying asleep. And so the early to bed, early to rise, early bird gets the worm pattern is something that most patients with Parkinson's disease notice. Okay? And this can be really bothersome. It can be a real pain when you're going to sleep at 8 o'clock and everyone else is staying up till 11 and you're falling asleep at the dinner table, etc. because you're early, you're shifted early. And then the other reason it's a pain is because it's 3 in the morning and you have to get up and it's very difficult to move and you're not feeling very well, and so your poor spouse or partner, if you have one, is on normal sleep time and they have to deal with you waking up in the middle of the night, etc. So you can just imagine the difficulty with having a desynchronized schedule. Most of the time, in fact, most people with Parkinson's disease actually have a normal sleep duration. So it's not like you're not sleeping, it's just you're sleeping too early. So if you fall asleep at 9 o'clock and you wake up at 3:30 in the morning, don't be surprised. That's 6.5 hours of sleep, which is normal for your age. Okay? Now, some people do have a lot of trouble falling asleep, and so yes, they're falling asleep at 11 and they're waking up at 1 and then they wake up at 3, and so it can vary. Everyone's a little bit different, but just be aware that you don't necessarily have a problem with the total amount of sleep, although some of you do. And so this is a really key point, because everything you're going to read when you go on the internet, you're going to read up on insomnia, is usually applying to the people who don't have Parkinson's disease, who have trouble falling asleep. And so all of the advice that you might be getting related to that is, it might be okay, but it doesn't really apply to you. And so all the things that work for helping people fall asleep don't necessarily help people staying asleep. So what can you do about insomnia? Well, we'll go over that in a minute. Now, why do people, let me see, am I out of order? No, I'm not out of order. Okay, so why does insomnia happen in Parkinson's disease? Well, I don't know how well this is projecting, okay? But this is a sleep map, okay? This is a map. My pointer will come too soon. There it is. This is a map of the sleep centers of of normal people, And everything in purple, I don't know if you can see that, are areas that are mostly involved with having us fall asleep. Okay, so this is the clock rhythm of the brain. This is some areas of the brain that start sending signals to this area to ignore all the stimulus that are going on, start ignoring the noises, they're not important, fall asleep. But the point is, if someone is worried because they're giving a lecture tomorrow or something, whatever it may be, and they can't sleep, they're not sleeping because it's all up here. They're thinking about their work, they're thinking about this, they're ruminating about that. But in Parkinson's disease, it's a problem down here. And remember, I showed you this map here, which is the Parkinson's disease pathology, okay? And you can see that the areas involved in sleep are very closely connected to these areas involved in Parkinson's disease. So the usual reason you can't sleep in Parkinson's disease is not one's fault, it's nothing else, it's not anything you're doing, it's the disease itself. So what can you do about this? this, okay? Now, if you've gone on the internet because you couldn't sleep and you're looking up sleep hygiene techniques, there's a lot of things that they'll say, you know, don't drink coffee, don't drink alcohol. Some of those apply and some of them don't, okay? This is a list of what actually applies to you if you can't sleep, okay? Avoid late naps. Okay. Now, that's the opposite of what you read in for a person without Parkinson's disease, which is avoid naps altogether. In fact, I find a nap at 1 o'clock can often help the problem because it makes you able to stay up longer. I think once you're after 5 p.m., you better be careful about those naps because they're going to screw up your night's sleep. But late naps avoid, early naps are probably okay. Caffeine is actually probably fine, okay, as long as you don't have it after about 4 p.m. Because again, what's caffeine doing? It's keeping you awake. That's not your problem, okay? Your problem is 4 in the morning when caffeine's long out of your system. Caffeine lasts about 6 hours on average. Alcohol is probably okay, except that it might make you fall asleep too early. And if you drink too much of it, actually alcohol makes you fall asleep and makes you wake up early. So that's a difficulty that can happen with alcohol. Get a lot of exercise, and if you can exercise in the late afternoon and early evening, that's the best, because it's very hard to fall asleep if you've exercised 1 hour previously. Some people can do it, but I certainly can't. I have to give it 6 hours. So exercise can help a lot, okay? And get daylight exposure as well, okay? And especially the afternoon. It's not you get up at 5 in the morning, you get the sun in your eyes. Well, that's resetting your circadian rhythm earlier in the morning. Really try to seek out that 5 in the afternoon daylight, and that can help you. The single thing I think that's the most important thing for sleep hygiene technique is if you cannot stay asleep, don't stay in bed. Okay? Don't lie there staring at the ceiling for hours on end, because what happens to you is that you get an association between the bed and this horrible torture chamber where I can never sleep. Okay? You want an association between bed and sleeping, and if you're not sleeping, you're not in bed. Okay, up you go sit in a chair. You can even put it in the room if it's difficult to get around, and do something, you know, mildly stimulating. Maybe not a big screen TV with that big light blowing in your eyes, waking you up, okay? But reading a book, that sort of thing if possible, okay? Don't stay in bed if you can't sleep. Easy to say, of course, if you have a lot of trouble getting out of bed, of course, that may not be possible. But for those of you who can, really try to get out of bed. Now, that's what you can do sort of without needing anyone else's help or input. But there's a lot of other things that can be done in participation, mainly with your doctor. Okay? The first thing to ask is, am I not sleeping at 3 in the morning because my Parkinson's medications have worn off? Okay? So tremor, stiffness, inability to turn over in bed, making you sore, aches in your muscles, restless legs, can all be signs that the medications are wearing off, and so that's why you can't sleep. So it's not hard you actually don't have, this is kind of interesting, you don't have Parkinson's disease while you're asleep in terms of the motor state. It actually disappears completely. But everybody, normal people too, wake up 20, 30, 40, 50 times a night without realizing it. So as soon as you wake up, if you got a tremor, you wake up, you have no tremor. As soon as you awake, thump, thump, thump against your chest, and that wakes you up fully instead of allowing you to go back asleep. So that's one thing that is quite easily fixable. So think about it. 5 in the morning, you last had your pill at, say, supper time. You are now the longest that you've ever been without medication. So maybe the fix is to bring the medications at night. And so when we deal with that, with my patients, there's a few things that we will do. We might try levodopa right at bedtime, and we sometimes use the CR form, Cinemet CR, some people use that. Lasts a little bit longer, less effective in general, but not bad for the night because it lasts a little bit longer. There's the other long-acting medication, so levodopa is up and down sometimes. The other medications are smooth. Okay, so we can sometimes give those at night. And what I sometimes try is if you're awake in the middle of the night at 3 in the morning because of your motor things, put the Cinemet next to the bed and take an extra dose in the middle of the night when you're awake. The other thing, of course, that we reach for very oftenly are sleeping pills, okay? And we use them sometimes, okay? We don't always have to avoid them. I mean, I do tend to avoid them, but you can use sleeping pills sometimes. But here's the problem with sleeping pills. So when they're trying to design sleeping pills, they're designing it for the people who can't fall asleep, which is 90% of people who have sleep troubles, okay? That's the big market. And so what they're doing is they're putting you to sleep. Well, you don't need any help putting to sleep, you need help staying asleep. And so all the short-acting medications, so the ones that help you fall asleep, are already gone by the time it's 3 in the morning, okay? So they're not helping you at all. And so then what you're doing is you're leaning on the long-acting medications, which can help, but they're long-acting, which means that they're there at 10 in the morning, at 11 in the morning too, and so they can make you drowsy, they increase the risk of falls, etc. So the typical sleeping pills aren't really a very good option. There's also the concern that sleeping pills can be habit-forming, and there's no question that some sleeping pills can be habit-forming. In general, these are what we call the benzodiazepines. So these are the medications that end with azepam. Okay, lorazepam, clonazepam, diazepam, temazepam. Okay, many of you are probably taking those. I don't like them. Okay, because they are habit forming. In other words, after you've taken them for a couple of years, it's like a thermostat being reset, and you basically need them to fall asleep now, and it's like they're doing nothing anymore. Okay. If you would get off them, you go through a withdrawal period, and then you'd be back exactly the same way that you were. That you can use them once in a while. But most importantly, they can make you sedated, impair your cognition, things like that. I really, really don't like to use these medications unless you're totally desperate. So what are some of the safer options? The one that you can try that's fairly easy to use is melatonin. Melatonin is the natural hormone of sleep. And so all of us, when it gets to be nighttime, have melatonin that's secreted that's telling us it's time to go to bed. Okay? And in fact, Parkinson patients lose that cycle. So sometimes a boost of this can help. But again, what melatonin does is it helps you fall asleep, and it doesn't help you particularly stay asleep. So it doesn't really help most patients with Parkinson's disease, but it's a relatively simple and safe option, and most people don't feel sedated the next day, especially if they can get up and get moving outside. The Z medications, and so that mainly is Zopiclone or Imovane. That's the one that we use most commonly in Canada. These are like benzodiazepines basically, but they're a little less habit-forming. So I do consider them a little bit safer than the other medications, but they can definitely still make you drowsy in the middle of the night. I always worry about the quality of sleep that happens with these kinds of agents as well as the benzodiazepines. Whether they are giving you that proper restorative sleep that you really need to stay awake the next day is not clear to me. I suspect that I take them once in a while, and I just feel groggy the next day. I feel exactly as sleepy as if I never slept at all. So I don't personally find them useful, and the only kind of insomnia I get is jet lag. So I'm not a fan of them, as you can tell. So I do use one that more than any others, and some of you who are my patients might be on this actually. This is Doxepin, okay, and it's unique because it doesn't help you fall asleep; it helps you stay asleep. Okay. Now, Doxepin is a funny medication. It's actually been around for forever, about 30 years, and it used to be used for depression. And in fact, it's a very good antidepressant. But usually for antidepressant doses, you take 300 milligrams, something like that. Okay. But it turns out that at very, very low doses, Doxepin is an antihistamine, which is kind of like Benadryl. Benadryl actually is an antihistamine that really helps you fall asleep too. And theoretically, this should cause cognitive problems because Doxepin at high doses does, but for some reason it doesn't really at low doses. And this is a study of sleep efficiency in elderly people. Okay, these are actually normal elderly people, without Parkinson's disease, I mean. Okay, and sleep efficiency essentially means how much of the night are you actually asleep and how much of the night are you actually awake. Okay, and the purple line, if my pointer will come, so this is the people who got the placebo group. They didn't get anything, okay? And there's not much difference between the medications and the placebo here, but what happens is the medications are starting to work at around hours 6, 7, and 8. That's where you really see the effect. And so I kind of like that, okay, because that is dealing with the actual problem that people have. No difference in falling asleep, but mostly difference in staying asleep. And so that's healthy elderly. We tried it in a very small study in Parkinson's disease. And we actually had 3 groups. We had a group where we were getting light therapy and sleep hygiene training. Okay, we got another group where we were getting the Doxepin medication. And then another group was getting an inactive thing that we didn't think would actually work. And what we found is that both of the therapies actually helped insomnia. Okay, but the Doxepin, in my view, actually worked quite a bit better, and it seemed to work a little bit longer as well. And so this is the Doxepin group. These are charts. You don't need to pay attention so much to it, but what happens is, this is what happens if nothing changes. This is how bad your insomnia is, and the insomnia dropped by quite a substantial amount in this. So I use it a lot. And there was a theoretical concern about cognition being worse, but in fact, the cognition slightly boosted with this medication, maybe because people were sleeping better and just a little bit more alert. So I use that a lot. It's not for everyone. You have to talk about it with your doctor because there's some interactions and etc. that make it complicated. So let's leave insomnia, okay, and let's move to the opposite problem. And it really is, in most cases, the opposite problem. So sleepiness does happen in Parkinson's disease. I saw a couple of people nodding off. It occurs in about 40% of people with Parkinson's, and this is generally a problem later in disease, okay? So, in fact, people just diagnosed with Parkinson's, not on any medications, don't even have any more sleepiness in the general population. But the more time goes on, the more this becomes an issue. Now, sleepiness has a lot of causes, okay? The first thing that you're going to think of is, well, it's because I had a crummy sleep last night that I'm sleepy today. But in fact, on average, that's not true. In fact, people who are sleepy tend to be ones who are sleeping all the time. They sleep 12 hours a night beautifully, and then they sleep 2 hours in the morning and another 2 hours in the afternoon. So it's a sleep drive problem. It's not really a reaction to insomnia. The other one that has to be considered, and I don't think this is an issue for most people, is sleep apnea. So the commonest cause of real bad sleepiness in the general population is sleep apnea. What that means is you stop breathing while you're sleeping, and it could be 20, 30, 40 times a night, okay? You fall asleep, you stop breathing, so your brain wakes you up. Then you fall asleep, you stop breathing, so your brain wakes you up. And if that happens 20 times in an hour, you're not going to have a very refreshing sleep, okay? And so this is not increased in Parkinson's. So this is not really a unique problem to Parkinson's. This happens usually, in fact, I think it happens less to Parkinson patients than the normal population, but it's still a common thing, okay? And so if you're overweight, okay, and especially if you have a receding chin, not a strong jawline, it turns out that your chin line makes a difference. This is the sort of person that gets obstructive sleep apnea, but thin people can get it too. And usually, if you have a bed partner, they're the ones who know all about it. It presents with snoring, but most important, it's not just snoring, it's just 20 times an hour. And so most people, spouses of sleep apnea patients, will readily recognize this. This is a treatable problem. You put these machines on, they're kind of hard to wear, but that would fix the underlying problem and can help sleepiness in some people if this is your problem. Again, most of the time, it's not. Parkinson's sleepiness can also definitely be caused by the medications, and so levodopa definitely does it. All of them do it. The only one, selegiline, maybe doesn't. It probably keeps people awake, but basically all the dopamine medications can make you sleepy. They can also help you sleep, which is another good thing. But some people, they keep awake, so everyone's really different. But many people notice that if they're taking especially a big dose, that they take the big dose, they fall asleep, okay, and then they have a little nap, and then they're awake again, they're okay. And some people have 3 naps a day because they're taking 3 Cinemets a day. The dopamine agonists, that's the pramipexols and the mirapex, these ones really cause sleep onset, especially when you're starting them for the first time. They can really cause sleepiness. Most importantly, though, it's a primary disease manifestation. What do I mean by that? Okay, you've already seen this. I'm going to show the other half of the curve. So everything that was in yellow, I think you can actually see that there, is what keeps you awake. And what's keeping you awake is actually a huge number of different nuclei, all in the brainstem, all spreading up around here. And here's our Parkinson's map. So it's not surprising that people with Parkinson's disease are going to have some trouble staying awake. And again, it usually happens later in the disease. It's one thing to fall asleep when you're lecturer is giving a boring talk. It's another thing to fall asleep when you're driving. Okay, so this is something you really need to be aware of. So this happens to Parkinson's patients. It can happen regardless of medications. Okay, but essentially what I tell my patients who I think are sleepy is your sleep regulation system is not normal. So unlike most people who feel sleepy and fight it off and feel sleepy and fight it off, you can't necessarily fight it off, and you can fall asleep like that. Okay, in 1 second you can be asleep. So the key is, if you are feeling drowsy, you do not drive. And if you're feeling drowsy while driving, okay, and you're fighting, if you feel yourself even fighting a little bit, you have to pull over, get up, walk around the car, whatever it takes, okay, because you could fall asleep in 1 second. And obvious consequences, right? Never drive drowsy in Parkinson's disease. Okay, so I'm sleepy. okay, or my husband or wife is sleepy, that's usually the spouses who notice it most. What can I do about this? Well, again, if you have someone who knows about your sleep, ask them if you snore, ask them if you stop breathing at the night. Actually, you can get these apps now, they're all over the place. You have these health monitoring apps that will automatically turn on when they hear a sound in the room, and so you can get an idea of how often you're snoring or making noise in the middle of the night. Get light exposure. Okay, now whenever you're sleepy, just get the light. Light is a signal to your brain that it's day and you're not supposed to be sleeping. So blast it in there, okay? And in the winter, you know, those lights, in the summer, outside is way stronger, okay? It's way stronger than any light you can get. And in the winter, it can be a little bit difficult, so sometimes you use a light. For example, especially in the early evening, late afternoon, you get those lights, you know, those blue lights that you buy at Costco or whatever. You can use those, and they may help a little bit. Exercise definitely helps. Like I said, it's hard to fall asleep 1 hour after vigorous exercise. And I personally think that short naps are okay for people who are too sleepy. Again, avoiding 5 o'clock. But a little power nap just to get you, to give you that 2 hours where you know you're going to be awake, and it's not a bad idea. That's everything you can do by yourself, okay? What can you do with your doctor, okay? So when I have people who are sleepy, one of the things I'll do first is I'll look for those big dose peaks. So in other words, you're taking your levodopa, your Cinemet, it's 3 pills 3 times a day. So maybe a better solution for someone like that would be 1.5 pills 6 times a day, avoiding those peaks. Now that doesn't always work. Sometimes that turns 3 naps into 6 naps, but it's something that we may try, okay? So smoothing out the dopamine during the day. Ritalin, what all the kids are on for attention deficit. What it turns out, Ritalin is actually a stimulant, and stimulants calm kids down and wake adults up. It's the opposite effect, okay? And so this actually probably does help a little bit. There are no studies showing it helps, but because the next agent is $2,500 a year, the government actually requires that I prescribe this before I prescribe anything else. And so I start with a Ritalin. In fact, I've been surprised sometimes I actually stop there and we don't need to go to the next one. The other one that's been actually studied in Parkinson's disease, and there's been 3 trials on this, is something called modafinil. No one knows how it works. It works, but no one knows the mechanism. It's about $2,500 a year, and it's not covered by RAMQ unless we fill out forms of exception. So it's not always the best option to start with, but it probably helps. Which brings up something that I'm looking around the room, okay? Yes, most people. This is a sea change. This has changed the last 5 years. I'm seeing coffee cups everywhere. But 5 years ago, 10 years ago, most of my patients, if I'd ask them if they drink coffee, it would be, I'd sometimes get a reaction like I'm asking them if they inject heroin. It's like, oh, of course not, doctor. Coffee, that's bad for you. It makes your tremor worse, okay? And this is actually a phenomenon in Parkinson's disease. So non-coffee drinkers get more Parkinson's disease. And like even at the age of 20, at the age of 30, non-coffee drinkers get more Parkinson's disease. Now, does that mean that coffee prevents Parkinson's disease in sort of a direct way? I think there's no reason to necessarily think that. I think there's lots of potential confounds, okay? And we decided to check some of these out, okay? So one explanation that coffee drinkers don't get Parkinson's disease is that because maybe people with Parkinson's or born with a tendency to get Parkinson's disease don't feel coffee. It doesn't help them, or they don't like it. Okay. Another possibility is that coffee is actually a treatment for Parkinson's disease, and if that's the case, then we should all be on coffee, right? Okay. So we checked this out in a paper that we published about 4 years ago now. You may have heard about it because it was all over the news. And so we looked at people who were sleepy, who had too much sleepiness, okay, Parkinson's patients who had too much sleepiness, and we gave them coffee. We didn't give them coffee because that's complicated. We gave them pills with caffeine in it, okay, because it's the caffeine that counts, because you get the same effect with tea, for example. You don't get it with decaf. And what did we find? Well, we found, in fact, that there was a benefit of coffee on sleep. It was pretty mild, though. It wasn't as much as you might expect in sort of a normal population, but there was an effect on sleep, and we could see it. We had a couple of dropouts and some complications, so it was not quite statistically significant. It was the worst result you can get, a p-value of 0.06. Of those of you in research, nothing worse than that. But it was clearly there. Okay, there was a little bit of an effect on sleepiness. What we also found, to our somewhat surprise, is that there was some benefit on the motor symptoms of Parkinson's disease. And that's actually led us to go on to look at the possibility that coffee could be a Parkinson's medication. Okay, now I don't know if that's true or not. everyone who drinks coffee remembers for the first time that they drank coffee that, wow, I couldn't sleep for hours. And veteran coffee drinkers can have a cup at 9 o'clock and go to bed at 9:05 and fall asleep perfectly well. And so the effect that we saw on the motor may in fact be a very short duration effect. Okay? But if there's no symptomatic effect, and that's important because maybe it means that coffee is really doing something in the long run. If there is a symptomatic effect, we have a new medication for Parkinson's. So we're actually in the middle, getting close to finishing recruitment for a very large study of caffeine in all of Canada. We're doing a bunch of centers looking at caffeine and Parkinson's disease. The bottom line is it's okay to have coffee. Okay, not more than 3 cups a day, but you're not killing yourself with coffee. Okay, so if you're worried about it, stop worrying about it. So that's everything about sleepiness. I'm going to finish with, how are we doing for time? We're okay. I'm going to finish with a disorder called REM sleep behavior disorder. Okay? You may not be aware of this, but your spouse or bed partner or someone who shared that hotel room with you 10 years ago, it certainly is. And so normally when we dream, we're paralyzed, okay? So most of us, if those of you who don't have Parkinson's ever remember those dreams when you're trying to run and your legs don't work, or you're trying to punch and it feels like you're punching through water or something like that, that's because you're not able to punch and you're not able to run. Your brain is actually sending a signal saying something is wrong here, you're not moving, okay? But in Parkinson's disease, that system that keeps us paralyzed doesn't work very well, okay? And so in other words, what you dream, you're capable of doing. Most of the time, it looks like acting out of the dreams, okay? So if you're dreaming you're, combing your hair, you're combing your hair. If you dream you're running, you'll make running motions in bed. If you're dreaming you're having a conversation, you're having a conversation while you're sleeping, okay? Most of the time in Parkinson's disease, it's not a big deal. It's something that we just kind of notice, okay? And so sleep talking, of course, can be normal. Many people sleep talk, but it's a different kind of sleep talking. I don't know if for those of you who are spouses, you ever hear sort of, okay, all right, tomorrow then? That sounds great. And something like this. It's like you're listening to a person talking on the telephone because they're having a conversation in their dreams, and of course you're only hearing one half of that. The big issue that can happen is injury, okay, punching, okay, because you're fighting off an attacker and you slug your spouse next to you or the bed table or the wall. And the other one is falling out of bed. So my rule of thumb is any Parkinson patient who falls out of bed when they are asleep has REM sleep behavior disorder until proven otherwise. Because you were dreaming, you were thrashing, you thrashed around and you threw yourself right out of bed. This comes and goes a lot. I really find this, medications can sometimes bring it out. Most of the time medications make it go away. It really comes and goes. And so how do we diagnose this condition? Okay. Well, the ultimate diagnosis, in fact, we have to do a sleep study where they look at you sleeping. And they're not looking for the dreams. They're looking for a signal that the system that keeps you paralyzed isn't working very well. In other words, you're not paralyzed and you're making little movements, or you have what's called hypertonia, especially in the chin. That being said, it's hard for most of you to go in at night and have a sleep study, so we usually don't bother. If the history is really quite clear, we usually just proceed as if you have it, but if something seems strange, then sometimes we'll do a diagnostic test. What can you do about it? Well, there are some triggers. So even people without Parkinson's, if they have 4 or 5 drinks of alcohol, will commonly get this at about 3 in the morning. Okay? Antidepressants also. The antidepressants are a motor stimulant, and they can in fact do that in the middle of the night too, and they can make people move a little bit more at night. The other thing to do is, if you have this problem, the real big thing you have to do is you have to think about your safety. Okay? So not so much your safety as the safety of the person next to you is probably the key thing, okay? Because there have been injuries, let me tell you, okay? Some people would, so the ultimate cure of REM sleep behavior disorder is a mattress on the floor with pillows on the side and no sharp objects, and it's not a problem anymore, okay? Because it doesn't actually impact your sleep in any meaningful way. It's only injury. If it's a big deal, the main medication we use is clonazepam. Remember the azepam, okay, that I don't like, okay? It is the main treatment for REM sleep behavior disorder. It's very, very effective, okay? But we worry about it because of sleepiness and falls, etc. Melatonin, again, the natural hormone of sleep, probably helps us as well, not as much as other things. And so that's sort of practical management of this. I'm going to leave you with one last little wrinkle about all of the sleep stuff that I've been telling you about. So you remember I told you this at the beginning, Okay, and we talked about how Parkinson's disease is a disease that's not only motor, but the other thing we talked about is that the Parkinson's disease doesn't even start in the motor areas. And the idea that Parkinson's, in fact, starts in other areas of your brain. Well, it turns out this is actually probably one of the biggest things that's happening in Parkinson's disease, the idea that you can predict Parkinson's disease. And it turns out the sleep disorders can predict Parkinson's disease. Okay? So there's this thing called the Honolulu Asia Aging Study. It's this funny study that they did in 1971, and it was Japanese-American men living in Hawaii. Now, why would you do Japanese-American men living in Hawaii? It's because they were interested, in fact, in coronary artery disease, coronary heart disease, and they wanted to know if heart attacks were caused by diet or genes. And so you take Japanese men eating Hawaiian food or Japanese men in Japan, and you see who gets more heart disease. Okay. Has nothing to do with Parkinson's disease, but they did ask them one question. They asked them, do you fall asleep too much during the day? One question, that's it. Okay? And because everyone in that study is followed, and actually everyone gets autopsies at the end of the study, they were able to look and see Parkinson's disease. And the people who answered in 1991, this is not 1971, that they fell asleep during the day had a twofold increased risk of getting Parkinson's disease in the future. Okay? Proof, direct proof, that sleepiness can be a prodromal feature, an early feature of Parkinson's disease that starts before the motor symptoms. Now, this is not very much, 2 times, okay? So your lifetime risk of getting Parkinson's is 1 or 2%, so it goes up to 2 to 4%. It's not that big of an effect. However, REM sleep behavior disorder is something completely different, okay? And so many people with REM sleep behavior disorder are actually showing up in sleep clinics wondering what's going on because they're acting out their dreams at night, they're hitting their wives, it's usually men in fact who get this, etc. Okay? And as we've discovered, the majority of people with this problem go on to develop Parkinson's disease. And so this is a study that we did in 2009, actually we have one much more up to date, and these are patients that we've been following over years. My cursor will appear at some point, maybe it won't, okay. So here are people free of Parkinson's disease, and every one of these, every time you see a downtick like this, it's a couple more people getting Parkinson's disease, and this is the proportion of people who still don't have Parkinson's. So by definition, you have 100%, okay, and if everyone has Parkinson's disease, it goes down to 0%. And what we're seeing is 20% at 5 years, 40% at 10 years, 50% at 12 years get Parkinson's disease, and our longest term studies are now well over 70%. And so this is really unique. There's nothing like this in all of neurology, anything that can predict a disease with this much power. And the interval is incredibly long. So the mean interval between the onset of people's REM sleep behavior disorder and their Parkinson's disease or a related disorder is 13 years. And so this is a major research opportunity because first of all, you can study the early phases of Parkinson's disease. It's about the only way, really, that you can watch early phases of Parkinson's disease. And most importantly, and I hope this will happen at some point, it's the ideal means to test neuroprotective therapy against Parkinson's disease. What that means is we have great treatments for the symptoms of Parkinson's disease, but the underlying aging problem, that's actually the cause of the thing in the first place, we don't have treatments for that. Maybe it's because we're starting too late. Maybe if we could test it in these people who aren't being treated, and which confounds the study, all kinds of troubles with that, we could actually prevent Parkinson's disease from ever happening. And so this is, I work a lot on this, and that's what I want to do the rest of my career on, if we can get the right agent to test. Okay, so that's a lot of ground that we covered. So let's just summarize again, go over what we talked about. So to summarize, so remember, motor Parkinson's, that's a classic Parkinson's that we all remembered in the 1970s. So that's the bradykinesia, the rigidity, the tremor, the walking changes. But in the 90s and increasingly more now, we're starting to recognize the non-motor features of disease. These are treatable things, less treatable than the motor, but still nonetheless treatable. So it's important to be aware of them, okay? And then the sleep problems are common. Most people with Parkinson's disease have one of those 3 sleep problems. It's not always easy to fix these things, but we do have some things to help. And then the last thing is that these sleep problems may be the new frontier of Parkinson's disease, a way to diagnose disease and maybe even prevent it from ever happening. So with that, I'll stop. Thank you very much.
Thank you very much, Dr. Postuma. I'm sure you'll agree with me that this was very, very interesting talk. Now, up to you. If you want to have questions, raise your hand very high. We have someone going around with an open microphone for everyone to hear what your question is. So Stephanie is there with the microphone. Thank you. Thank you. That was great.
So, first of all, very good lecture.
Thank you.
Secondly, an aging person, and we seem to be living longer. What are your suggestions as of today that aging people can do to prevent Parkinson's before the symptoms?
Yeah, so what can we do to prevent Parkinson's? Actually, if I have to tell you something that I know would work, the answer is nothing. Okay? Parkinson's disease is a disease actually that happens to people who did nothing wrong. You can always blame lung cancer on smoking or heart disease on, all that diet that you ate. In fact, Parkinson's disease doesn't really have that. There's no lifestyle things that are obviously effective. So even coffee and smoking and things, yeah, but I don't think personally that they actually prevent the disease. The only thing that I think maybe has some evidence would be exercise, okay? Because we do certainly know that people who don't exercise have a higher risk of Parkinson's disease. Now, again, what does that mean? Is it because 10 years before Parkinson's you're kind of tired and you don't exercise? Is that the real explanation, okay? It certainly may be, but there's some evidence. There's some evidence from animal models, which is really the only way you can do this, that if you make them exercise less, they're more prone to Parkinson's disease from whatever thing you do to them to give them Parkinson's disease. So that's the only evidence that I think might indicate that you would prevent it. But this is not, by and large, right now, a preventable disease. Where's the mic? Yeah.
Thank you very much. A very interesting and informative lecture. I'd like to know what concerning me is driving. Mm-hmm. If my partner doesn't even know that he's fallen asleep, I watch him all the time because I'm afraid he might fall asleep, but his eyes, can he be sleeping with his eyes open? I see he doesn't close his eyes, and right now I'm concerned because you said he could fall asleep like that.
Yes, so you can't quite sleep with your eyes open, but you can get pretty out of it with your eyes open. You can be fighting it and be pretty close to be sleeping. So people who have cognitive problems in Parkinson's disease, especially if you see that there's memory problems and concentration problems that fluctuate up and down a lot, okay, that's a sign that there are times when you should not be driving. Okay, because what happens is the attention system, that's all related to a fluctuating attention problem. And so, yes, you could be sitting there and completely sort of stone out of it and just drive right into someone. Absolutely. In general, if there's substantial memory problems in Parkinson's disease, don't drive. Okay. If there are motor problems, okay, in other words, you can't imagine a child in front of you runs in front of you with a ball, and you can't imagine getting your foot fast enough from the gas pedal to the brake, you should not be driving. Okay. If you're having any trouble at night because of your vision, don't drive at night. Okay. But usually people with motor problems that are relatively severe and any sort of cognitive problems that are starting to fluctuate and become bothersome, or sleepiness, those are the people who should not be driving. The other sign is if the person next to you is nervous, you should not be driving.
Hello, thank you very much for your nice lecture. I'm a Parkinson's patient for 7 years, and I have a problem with sleep lately. I wake up after 3 hours. Sometimes I sleep right through. But when I get up, my body's like turned to stone because I've been in this position all night long, very little turning. And in the morning, I need like an hour to wake myself up again, or 2 hours. I do exercise, then I come back to life again. Why do I get so rigid during the night?
Well, it's exactly what I talked about earlier. So let's say you took your pills at 10, okay, or
11.
Yeah, okay, and it's 4, 5. That may be the longest you've ever been without pills, and so the pills are simply wearing off. That's certainly one explanation. Some people notice that immobility makes it harder to move, okay, but everyone's different in that regard. Some people have this great hour. Many of you may notice that you wake up and for an hour you feel like you don't need the medications at all. That's something called sleep benefit. So it's the opposite problem. So there's no hard and fast rule. My suspicion is from hearing that the problem is motor problems in the middle of the night, and it's the sort of thing that we often give middle of the night medications for. Yeah. And the other thing I want to say is, if you go to bed at 10 and you wake up at 2 and you're awake for 4 hours, then you go to sleep at 6 and you wake up at 9, if that doesn't bother you, then just go with it. don't fight it, okay? In fact, there are studies from the Middle Ages, not studies, but people have done these readings of texts, and they talk about first sleep and second sleep. And so in the days before lights, okay, there's nothing to do at 8, so you just went to bed. And so in fact, the natural sleep cycle may in fact be go to bed at 8, wake up at midnight, stay up for 4 hours, go to bed at 4, wake up when the dawn comes out. In fact, that actually may be the normal sleep that happens if we don't have electric lights and televisions keeping us awake. So if you can fit it into your lifestyle, just fit it into your lifestyle. You don't always have to fight it.
Yeah, thank you very much. What about the marijuana, cannabis, medical marijuana? They saw advertising for Parkinson.
Yeah, marijuana and Parkinson's, there's really no evidence it does anything in particular. Lots of people notice that when they smoke, they feel better, okay? They're also high. I mean, so if you had to make it as a medication, you'd be quite worried about the side effects, right? I mean, it's certainly worse than levodopa. I mean, I'm not opposed to it, but in fact, the evidence that it sort of makes a difference in any sort of good way has not properly been studied yet. So I don't think we can comment much on it.
You say about the melatonin.
Mm-hmm.
They have a sleep plus melatonin with passionflower. The melatonin.
So yeah, the melatonin is not very regulated. So I mean, melatonin with passionflower, I don't know. I mean, I assume that's a lot of herbal medications will sort of take 35 different herbs and throw them all together. And you're outside of the realms of science then. We have no idea what's going on when you put 35 herbs in your body. But melatonin is a natural product, usually made synthetically. And, if you're going to the big name brands, you're probably okay. If it's mixed with a lot of other things, I have no idea what the quality is. Nothing special with passionflower that I'm aware of, no.
I feel a bit awkward with this, but I'll speak up and ask my question. I have a love-hate relationship with this levodopa because it makes me sleepy and it drives me nuts, but it seems to help, I guess, with the mood. It doesn't help that much with too many other symptoms. I take it controlled release 2 times a day and the yellow pill at lunch out of necessity. I guess my question to you is, what would you suggest, how it can help me, and I only take it in a limited number of times.
Okay, so I can only answer any questions in generalities, okay, because I'm not your doctor. So yes, levodopa can make people sleepy, and that's a tough thing to deal with because it so obviously helps everything else. I sometimes use some of the alternate medications. I like selegiline because it tends to keep people awake. It's actually metabolized to amphetamines. Selegiline, Selegiline. Yeah, they name these things on purpose so they're hard to spell so that no one can remember them. So we use the brand name. That's actually true. Okay, selegiline. So sometimes that can keep people awake a little bit. Caffeine, but yes, it's an issue, and sometimes there's just no solution to that. Sometimes the solution is a quick power nap for 5 minutes.
Can I make an appointment?
You can fax my secretary. Yeah, and of course, yes. Your doctor would have to fax something. Yeah.
My doctor what?
Your doctor would have to, like anything else, has to refer. Yeah, exactly. Yeah.
With the evidence you presented about caffeine, do you recommend caffeine in patients, even those who don't like drinking coffee now?
No, I think if you're sleepy, I use it sometimes, okay? And I often, because if you don't like coffee, I sometimes give it as a pill. And it does help, but I don't want to overstate it. It doesn't help a lot. It helps a little bit, and it's an easy, simple thing to do doesn't have any harm, okay?
To get into that caffeine study you mentioned?
Yeah, we're closing recruitment actually, I think, because we're getting our signal already. So we may have the results published fairly soon.
Yes, it was a wonderful conference. I really appreciated it. You've said that antidepressant can trigger problems. Many of the older people, they have antidepressant, like I have Celexa, for example. So is it good or bad?
So the problem that antidepressants trigger, okay, is this one specific problem, which is REM sleep behavior disorder, the acting out of the dreams at night. They're not really a problem for the rest of your sleep, okay? In general, actually, the old ones are great for sleep, but sometimes they can cause, the old ones sometimes cause memory problems too. So in general, if you get, you start an antidepressant and you're acting out your dreams a lot and you're throwing yourself out of bed and you're hurting yourself, then maybe that's a signal that you want to get rid of the antidepressant, okay? But that would be about the only reason from a sleep standpoint that I'd be worried about it at all.
Do you think it's possible there's something in coffee other than just the caffeine that makes a difference? Maybe some of the xanthines?
Yeah, good question. So it's impossible to say no, okay? But the effect, you see it in tea as well. So Chinese studies, for example, see it in tea. So now you have to look for something common in coffee and common in tea. So you're lowering your list. And then the other thing is that you don't see the effect for people who drink decaffeinated coffee. And so now we're really running out of things that are common to both, that not in one. And so really about the only thing that's in that is caffeine. There are studies looking at green tea extracts. There some Chinese people were very interested in, Chinese researchers were very interested in that because of this effect, and it didn't look very good in their early returns. I think it's probably caffeine, but I can't tell you 100%.
I don't get the same effect from tea, so. But we drink our tea very light.
Oh yes. So the effect I was talking about is the preventative, in big quotation marks, the association between non-coffee drinking and Parkinson's disease. That's where you see that. Okay. Strong tea has about half the amount of the coffee that you just had per milligram. Weak tea, of course, is way less. Espresso has less caffeine than brewed filtered coffee like that. Starbucks has like 3 times as much as any other coffee. It's really quite something. So it's very different, yeah.
And in terms of the caffeine tablets, I actually started getting cardiac side effects from 100 milligrams of caffeine a day. I think I'm a slow metabolizer, and I was building it up, so I had to reduce the dose. So. Yeah,
so you get palpitations sometimes, okay, which are actually quite benign. If you have an underlying heart rhythm disorder, supraventricular tach, then that can make it worse because it speeds up the heart disorder. It doesn't cause heart problems, but yes, if that's an issue for you, then you have to avoid it.
I wonder if you could elaborate a little bit more about the thing at the end of your talk about predicting Parkinson's.
Well, so the NIH recently had a panel where they decided what are the 3 most important things that we should be doing in Parkinson's disease for clinical research. And number 1 was this, okay? The idea that you can detect people early, okay, and do something about it early, okay? Because if you have Parkinson's disease, on average, by the time you show up in the clinic, you've had it for 10 years already in your brain, probably, okay? So we've lost a big window of opportunity, okay? The difficulty is that we don't have treatment to slow down the course of Parkinson's disease. Okay? So there's 2 things. I have patients with REM sleep behavior disorder that I see every day, and I don't do anything different. There's no magic medications for them that are for other people. But one nuance is that, this is the ideal population in which to test these agents. Maybe the reason that all the other neuroprotective therapies that people have tried, and they've been trying, let me tell you, maybe the reason that they've been failing is because it's all too late by the time we're getting going in there. Okay, maybe they're just the wrong agents. There are some agents coming along that are exceptionally interesting. Agents actually looking at the synuclein protein, trying to clear it out of the brain. That might be something that could help everyone with Parkinson's disease, but it's definitely something that would help people with the early stages of Parkinson's disease. So we're trying very hard to get the companies who make them to get interested in it, but these are $100 million bets that those companies make, and if they lose $100 million. So it's hard for them to get involved. They're very motivated because they'd make a lot of money, but it's very, very hard to get these agents into trials and to get them moving.
So just to clarify, individuals who have REM sleep behavior disorder are dramatically more likely to develop Parkinson's later.
That's right.
If someone's having a nightmare, is it dangerous if you don't wake them up? Will it resolve by itself?
No. Well, okay, it depends. So sleepwalking, okay, which is not REM sleep behavior disorder, okay, that's really a different thing. It can be a little bit dangerous to wake those people up sometimes, or at least when you do, you have to be a little bit careful about it, just gentle, sort of push them towards the bed, because they're confused. They're half awake, half asleep, and they may lash out at you. A REM sleep behavior disorder episode is REM sleep, and with REM sleep, you have a trigger. You're in or you're out, okay? So all you have to do is give him a punch, okay, or whatever it is. He wakes up, it's gone like this, instantly. So you can wake up a REM sleep behavior disorder patient without any danger.
And you should.
Well, I mean, if they're just thrashing around and not hurting anyone, they can go ahead and finish, and the nightmare will end and they'll sleep, right? It doesn't really, so that might even be better, but if there's chance of injury, that's when you really have to intervene. You do not have to wake a patient up who's having an episode.
The deep brain stimulation, is that only to control tremors, or does that do anything else for Parkinson's symptoms?
It's really, deep brain stimulation, in a word, is electric Cinemet, okay? It doesn't do anything that Cinemet doesn't do, okay? The only thing is it's 24 hours a day. So some people get better sleep on it, but they're just simply getting better sleep because it's 24 hours a day, so it's like they just took levodopa an hour ago, okay? So no, the deep brain stimulation is really a motor treatment. All of them Parkinson's motor, but it's nothing for non-motor particularly.
I'm just wondering about the risk of developing Parkinson's. So I have a two-part question. Number one, do victims of concussions have a higher risk of developing Parkinson's?
So yes, a little bit. You have to have a concussion that knocks you unconscious, and then the risk goes up by about 50%. So that's not much, okay? That means your lifetime risk went from 2% to 3%. It's not a huge thing, but a big head, this is big head trauma, like go to hospital for it. Then yes, little bangs on the head, there's no real reason to think that it should be connected.
Okay, and part two, genetically, do siblings have a higher risk of developing Parkinson's?
Yes, they do.
And what is the...
So the way that... So the rule of thumb is for an average Parkinson patient, okay? So not a 20-year-old or a 30-year-old with Parkinson's. That's probably genetic if you're 20 years old. But so, average 50, 60, whatever it is. So your siblings, your children have a double risk, okay? And your siblings have a tripled risk. Okay, that's just a general rule of thumb. Now that varies a lot depending on ethnic group, for example. It's very different in some ethnic groups than others, but that's a general rule of thumb. So again, that's now 2% goes to 4%, okay? So we're still talking about 24 out of 25 chance that nothing's going to happen, okay? And siblings, 4%, 2% up to 6%. So it's not a huge issue. If there's multiple members of the family affected, then obviously there might be something else.
Third part then, so which ethnic groups do you see more prevalence of Parkinson's?
There's prevalence of familial Parkinson's, okay, Jewish, North African Arab. Those are the two ethnic groups that have two genes that run through the population in relatively high proportions, okay? But these are two genes called GBA and LRRK2. LRRK2 is basically only Jewish and North African, okay, so same genetic pool, okay, and GBA actually is everyone. Jews have it a little bit more, but actually French Canadians have a fair amount of it too. So
thank you very much.
A little bit off the research topic. Many people don't know how to get a specialist in the sleep disorders for Parkinson's. Is there a list or some way we can contact doctors if you wish to follow up on your own?
Specifically for sleep?
Specifically for sleeping, yes.
Yeah, in Montreal, you're looking at it. That's it. I mean, it's me and no one else who does sleep. Okay, but I mean, any Parkinson's specialist like a real Parkinson's specialist who knows what they're doing knows how to handle a little bit of the sleep issues as well. That's for sure.
Can we get your number?
Yeah, sure. I work at the General Hospital. Call the General Hospital 934-8026. But yeah.
Two questions. First one is related to two drugs on the market. I'd like to know your opinion about them. One is called TAS-IGNA, and the other one is called levocarb.
Levocarb is Sinemet. Okay, Sinemet is the main medication for Parkinson's disease. No one lives without it. Okay, the second one.
TASIGNA.
Tisagni?
New drug to be used for Parkinson's.
Tisabri? Yeah. Okay, I don't know. That it's a brand. The difficulty is that what you've read is a brand name. Okay, and so the brand name might be different in Israel and America.
The website is opdivo.com.
Okay, yeah, I don't know what that is. Okay, it sounds a little bit like a long-acting levodopa preparation that recently got developed. I don't know if that's it. Ritabri. Unfortunately, that's a brand name you gave me, and so the brand name is different in Europe and America and Canada and Israel and etc. So I'm not sure. Yeah.
Okay. My next question: are you familiar with the CyberKnife?
CyberKnife. So I think you're referring. There's a couple of things that could be referring to. One is the focused ultrasound, which is kind of a new thing, and the other is a gamma knife, I think maybe. And so these are ways to put a hole in the brain, okay, without having to put a hole in the skull, essentially. And so one focuses radiation, like you would treat for cancer, focuses radiation on an area and tries to put a hole in it. And the other one uses ultrasound waves and uses the heat effect to put a hole in it. These are being explored as possible surgery alternatives in Parkinson's disease. Let me rephrase. In tremor, okay, it works. They're much better for tremor that's not Parkinson's disease than for Parkinson's disease, because in Parkinson's disease you cannot miss. You have to be exactly right on the target, whereas in the other kind of tremor you can miss by actually quite a lot and it still works. And so the targeting is very, very key. So people are starting to explore that. The gamma knife I don't think has much of a future because it produces a progressive hole. In other words, it gets worse as time goes on. The ultrasound I'm interested in, but it's very experimental at this stage. They're doing it in Toronto, but I don't even know if they're doing it in Parkinson's disease.
Thank you.
You mentioned genes associated with Parkinson's.
Mm-hmm.
I was just wondering, are they doing research to try and fix the genes
so
that it won't
yeah.
lead to Parkinson's?
Yeah. There's a lot of, every time a new gene comes out, there's a flood of research that goes into, most importantly, actually, what happens, usually the gene is, one or two families in the world with this gene, but it indicates that pathway, that protein, whatever that gene does, is important for Parkinson's disease. So a stampede goes towards that gene, trying to figure out what it's doing, why is it there, and can we target it with a medication. And so there are, in fact, companies trying to make medications based on the gene hits that we've had. Genetic engineering? Well, no. The problem with a brain is that every neuron that you have, basically, you were born with, okay? And we can't make new ones. You make a few new ones, but not very much, okay? And so you can't really manipulate a gene. If you want to manipulate a gene properly, you want to go to the egg or the sperm, and then actually you could do it. But no one does it, okay, for obvious reasons. But gene therapy is something that's a bit of a dream for now, but it may happen at some point. Where's the microphone?
The medication that you were wondering about is Melatonin.
Oh, Melatonin. Okay, yes, thank you. Yeah, okay, this is interesting. It's a very random study of what's called an EGF inhibitor, and the idea is that it would increase the function of the lysosome, which would theoretically clear synuclein. Okay, so it's not a dumb idea. Okay, and in fact, there are many of them. The difficulty is that medication in particular is a cancer treatment. Okay, and so long-term safety of this particular medication is a major concern. I've heard rumors, and none of this has ever been published. Okay, this is a press release, and so it's press release and rumors from talking to my colleagues that I can tell you about. Is that they had a 30% risk of heart attack. And so they're not going to push that one, but they're trying to find a copycat that doesn't have the heart attack risks. It's an interesting area. I don't know where it's going to go. No one's published it. The data just got thrown up at some meeting in Washington, and no one's seen it since. But it's a Novartis medication. They have it in-house, and I'm sure they're looking very hard at it.
Go with a couple questions before we end this conference. And I'd like to thank everyone for being here and remind you there's a quick survey you can fill on your table to share your appreciation of this event.
All right, when are we ending?
After these 2 questions.
2 questions? Okay,
Yeah,
2 more
5
questions.
minutes.
Yeah.
Does deep brain stimulation have any effect on speech? Positive.
Deep brain stimulation generally makes speech worse. It's the motor side effect of deep brain stimulation. The speech. Did you say speech or sleep? Speech. Speech generally gets more difficult. Okay. Yeah. Last one, wherever it's going.
D'après vous, docteur, quel pourcentage de Parkinson joue sur l'humeur et la prise de décision?
Appelle l'humeur.
L'humeur et la prise de décision. Tu dois prendre une décision?
Dépression, anxiété, problème d'humeur peut arriver pendant 40-50% de la population avec le Parkinson, quelque chose comme ça. Vous avez aussi parlé de problèmes avec décision, ça veut dire problème de mental.
Je dois acheter un vêtement, j'achète, je n'achète pas. Je n'arrive pas à prendre une décision rapidement.
Ah, ok, difficulté à faire la décision. Bon, ça c'est difficile à quantifier, je ne peux pas dire franchement. Souvent, les personnes se plaignent de problèmes comme ça, surtout les problèmes complexes. Pour analyser les décisions complexes, ça peut être difficile pour la patiente. Mais je ne peux pas dire un pourcentage. So the question was, what troubles can people have with mood? And there was 2 things, and having trouble with making decisions. And the answer is about 40 to 50% of people run into mood problems, usually anxiety more than depression. And trouble making decisions, definitely we run into it a lot, but I can't quantify that. It's usually complicated decisions. It's hard to sort of, lock down on the complicated decision. But it's not necessarily a problem very associated with Parkinson's. La question c'était est-ce que mes enfants ont un risque de développer le Parkinson?
Non, moi quand je parle de l'autre. Je suis pas de bonne humeur. Les enfants?
Ah oui, oui, ok. Irritable, ça veut dire facilement fâché, oui, ça arrive souvent avec le Parkinson, mais ça arrive, normalement c'est avec dépression ou avec anxiété, ou soit avec problème de concentration, mémoire, on devient fâché facilement. C'est pas nécessairement relié avec Parkinson, à mon avis. La plupart des personnes avec le Parkinson ont une humeur assez calme, enfin, je dirais. Si on compare aux autres maladies neurologiques, enfin, l'irritabilité, c'est moins qu'une personne avec Alzheimer's, par exemple. Great. I think that's it. I can take. People are going to get tired, so I can take questions at the front as well. I certainly don't mind hanging around. But thank you very much.
Thank you very much, Dr. Postuma, for this great talk. Monsieur, this is what.